So again, hello everyone, and thank you for joining us for today's webinar. Today's topic is Rural Health Clinic updates, processes, and strategies for leadership. This event today is being recorded as well as qualifying for ACHE credit. The credit survey and a link to where the recording will be posted will be sent in an email following the completion of the entire webinar series. I am Caleb Lozinski, the program coordinator with the National Rural Health Resource Center, which is providing today's webinar. If you would like, you can connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located in the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization in the chat box so we know who is joining us today. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You may learn more about our commitment on our website. All right, before I introduce today's speaker, I'm going to go ahead and get the pre-polling questions started. If you wouldn't mind filling those out at your convenience, that would be great. Is requesting to record this meeting. Okay, well, you learn something new every day. All right, so we have Steve Smith with Forvis with us today, who will be presenting. Steve is a member of the Healthcare Performance Improvement Practice Unit and serves as the practice unit's lead for rural healthcare performance improvement. He provides consulting services to hospitals, physician practices, rural health clinics, federally qualified health centers, and other provider groups related to revenue cycle performance, RHC establishment, operations, and compliance. Thank you so much for being with us today, Steve. I'm going to go ahead and stop sharing. Feel free to take it away.
Very good. Caleb, thanks for everything. Appreciate the opportunity to be with everybody here today. See a few new faces, a few old ones as well. So for those of you I've met, very good to see you again. For those I haven't, by way of introduction, I'm Steve Smith. I'm a director with Forvis, based out of our Kansas City office. And really head up our rural healthcare services for performance improvement. And a large portion of that has been RHC consulting, specifically here over the last, I would say, 5 or so years, as we've just seen a number of changes to the RHC program. We continue to see a lot of changes to the RHC program. Some good, some maybe not as beneficial. There's certainly some debates to be had, but it definitely is an ever-changing arena. And that's one of the reasons that we wanted to make sure that we had this presentation here today, because there is so much that's changing, specifically that's changed after 1/1, and certainly has the opportunity to change as we continue to move forward. So a bit on our agenda today, I do want to make sure that we touch on the all-inclusive rate, because there is now a definite strategic approach that we have to take to the all-inclusive rate and how that's managed. We'll definitely talk on some of the legislative updates, including what to do now that the PHE has been done for a while. Want to make sure there's some things that maybe we were able to do in the past that nobody's currently doing to avoid any issues down the road. We know the good faith estimates are out there. They do apply to RHC, so we do want to make sure we at least touch on that. And then definitely have some other strategic implications, I should say, that we'll need to touch on, and then definitely hopefully have some time for some Q&A. If after the presentation there's any questions that come up, my contact information is in the deck. Please don't hesitate to call, email, whatever you need to do. I will say I'll be traveling here this afternoon. I'm actually up at the National Rural Health Association Policy Institute in DC this week. So I will apologize in advance. If housekeeping comes in and tries to kick me out of the room, I do have a late checkout, but we'll see if that gets its way out to everybody. So if I drop off real quick, you'll know that I'm having a quick conversation to be able to stay in the room. But again, if you do have any of those follow-up questions, just let me know, and I'll get back to you just as soon as I can with those answers. So, as I mentioned, the all-inclusive rate, everybody has one. It's just a matter of how is yours calculated, and what does that ultimately mean for your organization going forward, and how do we strategically make sure that we maximize our opportunities under the all-inclusive rate. So first and foremost, we have to talk about the CAA caps that were put in 2021. So we know that this is going to be applicable to any new rural health clinic. So this doesn't matter if you're provider-based, if to a large organization, if you're provider-based to a hospital with less than 50 beds, or if you're a freestanding RHC. If you are new, these are going to be your caps. And ultimately, what's going to happen is you're going to get paid the lesser of these caps that are listed out here by year. So you can see for 2024, caps at $139. I'm sure that's not new news to anybody that's on the line here. Or the actual cost per visit as calculated by your cost report. So the cost report calculations have always been important, but they certainly continue to be just as, if not more important now that we're starting to see these increases on an annual basis going up 13 years. Now, again, this is if you're subject to cap. We'll get to those that were grandfathered here in a minute. But we know that we have the opportunity to increase our reimbursement by $13 every year. The strategic part of this, though, is we want to make sure that if we're subject to these caps that are up on the screen, we don't run into a situation where we have our cost drive so high that maybe we end up driving our cost by $50 per visit. That's good. We're going to be above the cap. We're going to maximize our reimbursement, but we do have a portion of that cost that's not going to be cost reimbursed. So ideally, we need to be doing periodic reviews. And this is going to be regardless of whether you're grandfathered in, whether you're subject to rates. We'll get to grandfathered here in a second. But we need to make sure that we're doing periodic reviews every 3 months, every 6 months. Just do some back of the napkin math to see how do we think we're pacing for our all-inclusive rate come year end. Because ideally, we want to be in that spot where if we know that the 2025 cap is going to be $152 per visit. Can we come in at $155, $160, $165 to make sure that, again, we're maximizing the cap and we're staying over the cap, but not so far over the cap to where we have a bunch of uncompensated care or uncompensated cost, that's going to go into that calculation. So in the old days, if you were subject to caps, if you were grandfathered, you got what you got and it was great. If you were freestanding or provider-based to a larger hospital, you had your $87 rate and you were largely always going to be over. Well, now we have to take that continued look. And again, do some back of the napkin math every quarter, every 6 months, whatever it is. Just make sure you have an idea for how you're pacing and are you going to be able to stay above that cap, but not blow that cap out of the water and really hurt what we're trying to do. So again, if we're on that capped rate, just a graphical implication here, if we know that our all-inclusive rate is $139, but our cost per visit, because we didn't want to get too aggressive, or this just the way that our costs ended up for the clinic, ends up at 114, and we saw 5,000 visits. Total revenue of 695,000 if we were able to be to the cap, 570,000 if we were under. So we've got a variance there of $125,000. Anyone who works in a rural health clinic knows that $125,000 is real money and can make a real difference for how your clinic operates. What kind of infrastructure can you have? What kind of systems can you have? Your technology capabilities, your ability to send patient reminders, whatever it is. We need to make sure that we're constantly trying to keep that in mind and really, again, just maximize our opportunity under that model. For the grandfathered organizations, it's a little bit different in that we know that your cost per visit is still capped. There's still a little bit of a misconception out there that it's not a capped rate. It is still a capped rate. It's just not capped at the legislative caps that were put in place by the CAA. That cap was established by the 2020 cost per visit that was on your cost report. And so based on that, it's going to grow at MEI every year. So you have to figure somewhere between 1% and 3%. Again, this is not going to be a large growth figure. So while our freestanding or our new rural health clinics had a $13 per year increase that they were going to be trying to shoot for, our grandfathers may have something largely different. They may only have an additional, call it $6, $7, depending on where that rate fell. you've really got to watch that 1 to 3% increase to account for MEI. And the problem there is we just don't know where MEI is going to land until after the fact. So it is a little bit of a guessing game. Some of the organizations that I work with have said, okay, we want to make sure that it grows by 5% every year, knowing that that's going to be slightly above MEI, but not so far above that, again, we have some uncompensated cost that's going to be hitting our RHC. So again, very similar math here. Again, if our all-inclusive rate was $244 for the 2024 calendar year, we come in at $219, again, 5,000 visits. You can see, again, we have that $125,000 net loss, if you will, for the RHC itself. So again, the big stress here is we just want to make sure that we're continually watching what that all-inclusive rate is doing, what our all-inclusive rate is paced to be at, or at least projected to be at based on our periodic reviews, and see if there's anything that we need to do to allow more cost to flow to the RHC in order to then maximize that all-inclusive rate reimbursement methodology. So again, we want to really just make sure that everyone is taking a very close look at how those calculations are made and where they're pacing out to be, and is there opportunity to increase our reimbursement under that methodology if we've had issues getting over that rate cap in the past. We talked about the impact of the public health emergency ending, and this is significant. And again, this is all the way back to May, but we have found as we're working with organizations from time to time, some of these items have been missed or may still be in place when they're not supposed to be in place anymore. So we do want to make sure that we're calling these out here. And the first is the staffing requirements have now been reinstated. It used to be that, or historically with the rural health clinic program, you had to have a nurse practitioner, PA, CNM that was in the building at least 50% of the time that the RHC was open. That was relaxed during COVID because they knew that there were going to be staffing shortages and issues that arose. So that requirement had been lapsed. That is back in place now. So just know that if you are due for your recertification survey, understand that you will have the surveyor likely asking for proof or your calculations that you can show that, yes, we had one of those provider types in the building and able to provide patient care 50% of the time the clinic is in operation. Again, this is not something that's been a huge issue for a lot of the rural health clinics that we work with, but just something we want to make sure that we point out and stays at the forefront of folks' minds. Temporary expansion locations. This is an area where we have seen some issues. So hypothetical case here, you have your rural health clinic, and then during COVID, you were allowed to have a temporary location. Some folks would set up a location in their parking lot, for example, to where COVID patients could be treated as a drive up or whatever it was. And that was allowed. You could actually bill and be reimbursed for that service if it took place in that temporary location. Again, that has gone away now that the PHE has officially ended. So if anyone is still operating any kind of drive-up services that are outside the four walls of your RHC, you have a temporary building where you're providing services, again, outside the four walls of what CMS knows is your RHC, you need to either stop that as quickly as possible or change your enrollment so that that location is then recognized as part of your RHC. Now, the issue that you could have is if there are two different addresses, so let's say it's 123 Main Street and 125 Main Street, they cannot operate as the same rural health clinic. Each physical address has to operate on its own standing. The exception to that is if you have a building where, again, we'll use 123 Main Street, Suite 200 is what they know is your RHC, and your temporary location was Suite, let's say 305. So different area of the building, not connected, but still within the same, what we call a parent address. If that is the case, that can still be considered a single rural health clinic. And that's the only exception to that rule. So again, if you have that same parent address, different suite numbers, they don't have to be connected. They can be at different areas of the building, but they do have to share that parent address. Outside of that, you either need to discontinue those services, or you would have to actually do a new enrollment and set that temporary location up as its own rural health clinic. So again, just a couple things to keep in mind there. The bed count, again, during COVID, For those of you that are provider-based to a hospital with less than 50 beds, you did have the opportunity to increase that bed count during the COVID outbreak to exceed that 50 beds. Again, that is gone. You have to stay under 50 beds. If you don't, you will be subject again, you will flip actually to the cap rates if you do go above that bed count. So again, this is not something that we've seen a lot of, but just keep that in mind. The last one is one that I definitely want to make sure that we call out here though, and that is RHC recertifications are now back up and running. And I know there's some people on the line, I believe, that have already had these happen. So with those rural health clinic recertification surveys, you're supposed to have it done every 3 years. That was put on pause during COVID. They decided that there were much bigger things that needed to be taken care of. They also didn't want their staff out there or the staff of the accrediting agencies out there in harm's way. So they did put a pause to that during the PHE. Now that that's gone, those are starting to spin up again. So that brings out a couple different things here. Number one is your program evaluation. Has that been done in the last 2 years or since 2 years since your last one is what I should say. So let's say you did it on 12/31 of 2021. If you haven't done that by now, you need to get one on the books and get it done. So in case the surveyor does come through, yes, you'll be more than 2 years, but you'll at least show that it's done. And you can have that conversation with that surveyor. But if it hasn't been done since 12/31/21, and that surveyor comes on site and it still isn't done, well, now we're 3 years plus. That's going to definitely cause some issues for a surveyor and could be a condition level deficiency. So you need to make sure that those program evaluations are getting completed if you've fallen behind. The other thing there to keep in mind is because those surveys haven't taken place, there are some entities who have not done mock surveys, not done a touch base on their own RHC to see, are we still meeting these requirements? Do we have medications that are out of date? Can we provide all the required labs that we're supposed to provide? We need to make sure that all those things are in order. So if that surveyor shows up on our doorstep tomorrow or next week or next month, whenever that is, we know that we're prepared. Sure, they might find something because they're surveyors, they're likely going to find something, but hopefully it's nothing major and nothing condition level that would risk our RHC status. So again, if you haven't started getting some mock surveys done, please make sure that you're doing that internally to make sure that things are where they need to be for the operations of your RHC and that you're meeting conditions of participation. That goes hand in hand with the emergency operations plan and your evidence binder. Keep in mind with your emergency operations plan, you should have had some testing that had been done, maybe some tabletop exercises, and your evidence binder, you've likely had some changes over time to the staff that's present, to any of the other information that's included in that evidence binder. Maybe your medical director has changed. We need to make sure that we have all that information up to date because we know when that surveyor does come on site, and they are starting to do this again now, they are going to look very heavily at those items to make sure that they've been done and that those conditions of participation are being met. If they aren't, you can certainly have some conversations with the surveyor on this is why, and maybe you'll be able to get through okay, but can't stress enough to make sure that these things are in order, they're ready to go. So if that surveyor or when that surveyor does show up, we're ready to go. We can get through that survey with no problems and we go on down the road. So legislative updates. As I mentioned, I'm up in DC here this week. We've had a lot of talk around the RHC Burden Reduction Act. And for anybody who's worked in the RHC area or arena, you've likely heard about the Burden Reduction Act at one point or another. This has been around for a while, but quite frankly, it just doesn't seem to be getting a lot of traction in Congress. This is an act that if it does not get put into publication this year or passed this year, it will have to be revisited. It's been on for 3 years now, and at that point, they do have to roll off these regulations. But there's a lot of things in here that make a ton of sense for our rural health clinics. First and foremost, aligning its physician supervision requirements with the state scope of practice laws. Every other clinic in your state has different requirements potentially than what your rural health clinic does. So we do need to make sure that that gets back to the state level. The second one I absolutely love, and specifically for those rural health clinics that sit on the same campus as a hospital, you're just on the hospital's campus, but you're still required to do these labs. You don't bill the labs. Labs are billed by the hospital, but you're required to be able to provide these labs to any of your rural health clinic patients. Well, if this ultimately is passed, that would actually allow the RHC to satisfy an on-site lab requirement if prompt access is available to the patient. And so what that means is, yeah, I've got this patient here. I need to do a hemoglobin test on them. I can have that patient go over to the hospital setting, get that done there, and then ultimately be able to, have that requirement be met. So huge opportunity to reduce not only the burden in terms of training staff, making sure that they know how to use the machines, their competencies are on file in the evidence binder and all those things, but also the cost. We know these things are not cheap. The machines aren't cheap. The supplies aren't cheap. If we can just have this over in the hospital space and allow that patient to go over to the hospital to receive those lab services, it can be a huge benefit. The third one has always been a little bit weird. It would allow the RHC to either employ or contract with NPs and PAs. As you may be aware, and likely are aware, you are required as a rural health clinic to employ at least one of those provider types. But if this were to go through, that could be done under contract, just like your physicians, your medical director, would just make that a lot more simplistic. Anyone who's tried to spin up a new RHC knows about the urbanized area issue that HRSA created a couple of years ago when they changed their definition. We had a lot of organizations that lost their rural status because of that change. And so now we're allowed to look at either the 2010 or the 2020. Does either one say that the location is rural for that census? And if so, we can use that. Well, this would fix that and would just say, hey, if we have less than 50,000 residents, it's rural. And you can, at least have that portion of the location requirements met. And then this last one is a admittedly soapbox of mine. You'll hear it here in a minute as well. But right now, as a rural health clinic, we are limited in the amount of behavioral health services that we can render because we have to be primarily engaged, so 51%, in the providing of primary health services, family health care, your OB, your peds, your internal medicine, and your family practice all fit into that category, but mental health does not. And we know industry-wide that mental health care is a component of quality primary care. And so this would then allow for rural health clinics to provide more and more rural health clinics or rural health mental health services, which we know that we need, and located in a mental health HPSA. Well, go out and look at an area, and you're likely to find an area that's a mental health HPSA if they're a rural health clinic. It is a vast shortage, and it's just something that we need to make sure that gets pushed forward. That's been a big talking point while we've been up on the Hill this week. So I'm hopeful that things will start to move forward, but time does remain to be seen. Telehealth. So this is another one that's a little bit weird. And I'll start on the right side of the screen here. So I mentioned before that, we can only provide so much mental health because we have to be primarily engaged in providing medical services, and in particular, primary care services. But now we are allowed to do mental health telehealth, and it counts as a rural health clinic visit. That's very different from the medical side. On the medical side, we don't get to count that as a visit. We don't get to count that or be reimbursed for that service at our all-inclusive rate. We get paid a special payment rule of around $98. And, there's some flexibility there. So we're certainly appreciative of the flexibility that we do have, but the reimbursement is lagging. Versus the mental health side, we get paid our all-inclusive rate. We get to count that visit on the cost report for that year, which we don't get to on the medical side. So it's just odd. It kind of flies in the face of, hey, we want to open up this opportunity to provide more mental health services. So we're going to allow you to do this. We're going to pay you higher for it, but you can only do so much because you have to be primarily engaged in primary care. So the one caution I would have for everyone, if you're considering or have already implemented doing mental health by telehealth, that's fantastic. I'm very happy to hear it, but watch your volumes. And also watch the amount of time that your providers are available to provide that service. Because when CMS looks at something like this, they can look at the available time that providers were able to see patients. So they would look at the primary care available time and then the time for any specialties. And if that specialty goes over 50%, then there are potential issues. Same thing for the volumes. If they can see that, we do 10,000, just to throw a number out, 10,000 primary care visits, we did 15,000 specialty visits between mental health, ortho, cardiology, whatever else we have running through the RHC, there could be potential issues there as well. So again, I'm thrilled to see that they've given us this flexibility and our ability to go ahead and do this and be reimbursed and counted as a visit. But we do have to watch our volumes and our available time to make sure that we don't put that 51% threshold at risk. We do have some newly approved provider types. So marriage and family therapists and mental health counselors. Now, again, what I'll say here is the very same thing. This flies in the face of that 49% cap on specialty services that we can provide. You've allowed us to do mental health telehealth and paid us accordingly. You're allowing us new provider types that are mental health in nature, but again, we have to cap what we can do. So, again, the message here is very much the same. Take advantage of this flexibility and this new opportunity if you can, but just know that you have to watch your available hours and the volumes of services that you're providing for primary care versus specialty. So again, just something to keep in mind there, but definitely good to see that they're allowing some new provider types. This is the first time in years that we've had a new provider type that's been added to the available rural health clinic provider list. So same story, second verse here. And we're going to spend a little bit of time on this because this one has some even larger implications, and that is the intensive outpatient program services. So an IOP is really for someone who isn't quite to the extent of, hey, they need inpatient mental health services, but it's more than we're going to be able to do on just a visit here and there. They need more services than that. And so that can be for a lot of things. That can be depression, that can be your substance abuse disorders. There's a lot of things that can qualify for that. But what this really is a physician certifies that, hey, this patient needs services for at least 9, but no more than 19 hours on these mental health services per week. And so that certification is a continual thing that has to be done continuously. But again, it's nice that we're seeing them open up these mental health services to rural health clinics. It truly is. And I really don't want to sound jaded here because I'm not. I love the fact that they're opening this up. However, one of the issues that we do run into is that cap. And I did see a question come through, so I'm going to back up a couple slides here. And I'm just going to camp out on this slide here for a minute. So the question was around the 51% of volume for Medicare telehealth visits. And so what ultimately happens is every year CMS has the opportunity, it doesn't always happen, but they have the opportunity to look at the services and the available hours for your clinic. 51% of those hours have to be primary care in nature. And so for CMS's standpoint, primary care in the RHC includes your family health, your OB-GYN, peds, and internal medicine. Those are the 4 categories that fall under that primary care header, if you will. Everything else, mental health, cardiology, your orthopedics, anything else that's being done in the rural health clinic setting counts as a specialty service. If the sum of those specialty services, either based on available hours of the providers or the volume of services that they've rendered, goes above 49%, again, that's as a sum for those various specialty services, your rural health clinic status could be in jeopardy. And so a continual look, just like we do with our AIR, needs to be done when we look at things like the volume of services that we're rendering, and are they primary care or are they specialty? So again, just something we have to keep that continuous eye on to make sure we don't go above 49% specialty, which again, does include our mental health services. So I hope that answers the question. If there are additional ones, please let me know. So going back, and we're not going to read off this list here altogether, but as we look at this, a lot of services that can be provided and reimbursed on the IOP. So, and you're looking at things like your family counseling, your patient training and education for issues they may be going through, diagnostic services, occupational therapy. There's a lot that can be done under an IOP. But what I want to be very careful to call out is some of the, what I would call constraints of this program as it stands today. So right now we have the IOPs that are going to be paid by a special payment rule. So you're not going to get your all-inclusive rate, but you are going to get a rate of $280 per patient per day. So there could be definitely some opportunity here from a financial perspective. And really that allows for up to 3 different services to be performed for that patient on any given day. I've got a link out here to the HOPPS proposed rule. There's a table in there, table 44, that outlines the various services that can be provided. At least one of those 3 services that you do on that day have to be from that list. Now, there are some things that have to be taken into consideration if you're considering doing an IOP out of your RHC. I know some organizations I've already talked to are doing IOPs elsewhere, and we're thinking, well, maybe we can have the RHC serve as some spillover space. Can we use that as a way to, be able to provide more IOP? The answer is yes. But again, there are some considerations that we have to make here. Number one, the costs and the visits for that IOP have to be removed from your cost report. So if that IOP is going to be housed in a section of your rural health clinic, the supplies, if any, that were needed, the staff time that was devoted, the square footage of that space, all of those things and any other expenses that may be tied to it have to be removed from your cost report at the end of the year. So that can be a record keeping difficulty, certainly, but it is something that you'll want to make sure that is in place. And then the other side of that then is, what does that do to my cost per visit? Am I hurting my other services by having these IOP services in-house? Or is it going to be a relatively small hit and I can take that, and maybe my all-inclusive, my actual cost per visit was already significantly enough above the cap. Maybe it's not that big of an issue. But again, something to kind of keep in mind of and do some back of the napkin math on to make sure that you have the ability to make that calculation and feel good about implementing that service. The other is, as we've talked about already, these are mental health services. So again, there is potential impact to that 51% primary care threshold. You are not going to be able to have a rural health clinic that does 80% IOP and 20% traditional family practice rural health clinic services. That's just not going to work. You would lose your rural health clinic certification, or at least would be likely to lose your rural health clinic certification if that were the case. So again, I'm going to sound like a broken record here, admittedly, but I love the fact that they're opening up rural healthcare and opening up mental health services to rural healthcare. The problem is the way the regs are written right now and the way the statutes are written right now, it doesn't allow us to fully engage in these services in a way that we may want to. So we've seen a lot of motion here, as you can see, on expanding mental health and getting mental health into these primary care areas. The hope, and believe me, it's a big hope, is that we would then be able to have some flexibilities allowed to us, but time will tell. And what I will say is, knowing that we're in an election year, how much is really going to get done between now and November remains to be seen. I'm admittedly a little bit skeptical that we're going to see much movement, just because traditionally this is a little bit of a dead time from a regulatory and legislative perspective. But we'll have to see. Again, I have no, boy, I wish I had a crystal ball where I could say, yep, I think this is going to happen, or no, this isn't. We don't have to worry about it yet. Certainly don't have that. If anybody does, let me know, but something that we're at least hopeful for, that we'll see some movement on that front going forward. We also did have an expansion of rural health clinic care management. So for any rural health clinics that are out there right now that are providing care management services, remote patient monitoring, your remote therapeutic monitoring, community health integration, principal illness navigation, historically, you were only able to bill one GO511 per month. And so, it just wasn't a real implication or representation of the work that your clinic was doing and that your providers were doing. Now, however, there has been a change to where, effective the first of this year, we can bill those services multiple times per month. So we still have the GO511, which I am not a fan of. just because it really doesn't give the full detail of exactly what services we've rendered for that patient. So we still do have to use that special billing rule. But the good news is we can at least bill it on multiple times per month and have the ability to truly be reimbursed closer to the level of work that what we're doing. Just keep in mind that does have to be done by a qualified provider. So it can't be your nursing staff that are out there doing these things. It has to be a qualified rural health clinic provider that's providing these services. But as long as they are, they can be billed multiple times per month, effective 1/1 of this year. Good faith estimates, everybody's favorite topic, I'm sure. I will say if your front desk and your scheduling departments aren't already doing this, really do try to make an effort to get this put into place. This has been around since 2021. We haven't seen a ton of enforcement around it, primarily because of COVID, as well as what I'll call the newness of the requirement. But we're getting outside of both of those now. So I do expect that the policing and the penalties related to good faith estimates, or more specifically, the lack of providing a good faith estimate, is likely to increase here in the future. We'll see where ultimately that lands. But again, if this isn't something that you're doing right now, please make sure that you have it put in place as soon as you can. The reason this has become a very big issue, specifically for rural health clinics, we know that we typically see a higher volume of Medicaid patients than some other clinics may. What that means for us in terms of good faith estimates comes down to unwinding. So public health emergency ended, and now we've had a lot of patients that are losing their Medicaid coverage, which had just been continuously re-upped, if you will, over a period of time through COVID. Well, now that's stopping. And so patients are losing their Medicaid coverage and becoming self-pay patients. Well, what that means for us is if they are that self-pay patient and they make an appointment, we're now required to follow the good faith estimate process. We now have to make that determination. So your insurance verification staff, if that's at your front desk, if that's in your scheduling department, wherever that is, they play a very critical role now, in that they have to be able to identify, yes, this Medicaid coverage is still active, or actually that Medicaid coverage has termed. Unless you can provide us something different, you're going to have to be treated as a self-pay patient, which has its own implications for the patient. But then we as an organization need to go through our good faith estimate process and get that estimate out to that patient for that service that they've scheduled for that day. Really do, if you haven't already, make sure you're doing some proactive communication to your community that you serve. Making sure that they're aware of what this unwinding means. Your front desk staff certainly needs to make sure that they know what it means, so that if a patient comes in and says, well, I had my Medicaid coverage, 3 weeks ago, and now, you're telling me I don't. And they do need to be able to have that conversation with that patient. And quite frankly, your scheduling department, if you have different folks doing scheduling, would be beneficial for them to be able to have those conversations as well. So that patient knows what to expect if they're going to come into the office and now they're a self-pay patient, where maybe they've had Medicaid for the last 4, 5, 6 years, whatever it is. And then for one reason or another, their coverage was unwound. They lost that coverage. Now they are going to be treated as self-pay. So again, we need to kind of keep that in mind there, and make sure that we're able to have those conversations with those patients so it doesn't come as a surprise. Again, for your staff, make sure they have those conversations. They're able to know what it means, why they may have lost their coverage. They can have, and again, we're not talking about an in-depth conversation here, but they can at least walk the patient through, hey, really sorry, it looks like your Medicaid coverage has turned. We've seen this with some of our patients because of the, unwinding of Medicaid coverage across the country, and be able to have, again, that conversation. But the biggest thing I want to focus on here is underneath that second bullet point, there has to be an increased focus on insurance eligibility checks. Number one, we need to make sure the patient knows what to expect. They're going to be expected to, pay for their services, at a full bill charge or whatever kind of sliding fee that you may have. That's going to have an impact to them. For our staff, what additional information do we need to request from that patient? And what does that mean for us? And then also for us financially, as we start to look at what our payments are going to be. I've actually seen some organizations that have started to have Medicaid qualified individuals in their clinics that can actually help a self-pay patient qualify for Medicaid on the spot. What that does then is gets them out of that self-pay bucket and gets them more so to a paid rural health clinic visit that may be at your all-inclusive rate or whatever rate that your state has set up for the rural health clinics, excuse me, but can definitely be beneficial. So, you know, again, I just come back to the education, the communication about this change to internal staff, to the community that you serve. Ultimately, making sure that we have this ability to communicate the message is going to be critical to making sure that we navigate this successfully. And ultimately, when it ends up is if we're unable to get that patient qualified, then again, that good faith estimate does come into play, and we are required to give that to that patient. So a few different things that you have to have in place here. Number one, make sure that you've got some signage up about a good faith estimate that just, you know, lets them know about what it means, having information out on the website, making sure that somewhere, if someone were to come looking at it, there's some prominent display, again, website, clinic, whatever it is, to show that, yes, you are eligible for a good faith estimate, given certain circumstances. We'll walk through those here in a second. Verbal notification. So again, we have to make sure that we notify those uninsured or self-pay individuals of the availability of a good faith estimate. Now, again, we'll get into this in more details here in a couple slides, but there are certain instances where you're not required to give a good faith estimate. And there are certain instances where you are. So we'll go through those. We do have to make sure that we can communicate that and provide that to the patient in a written or a printable format. Now, this could be done at the front desk. So your front desk staff could go ahead and print this off, hand it to the patient, and you're good to go. You could also go through a portal, and you could have the ability to submit that securely on your patient portal if you have one, and get them to that way. The reason I like the portal as an option is you have timestamps. And again, that's going to be, we'll talk about the timing requirements as we get to the next slides. But that can be a really great way to do that. One thing I will call out here is I have worked with some clinics who do email this information. I don't love that as an option just from a privacy standpoint. The last thing we need to do is have a privacy breach or anything like that we have to go out and report. So I don't love the idea of email. If you can do it securely, that's okay. But there's just more risk that comes with that. So really, we've kind of tried to drive folks towards either have that printout available at check-in or get it out to the patient portal. And again, you have that timestamp there at that time. Then we have to make sure that it gets into the medical record. So if you are going to be issuing that when a patient checks in, make sure you have a second copy available for your staff that can get scanned into that patient's record. Same thing on the ones that are going to be uploaded to the portal. We need to make sure that it's on the medical record for that day, and we do have to retain that for a 6-year period. So just make sure we have those capabilities in place. Now, I talked about timelines, and there's a lot of different if, then, else statements that happen here. So number one, patient calls up, hey, I've got a sore throat, I need to get in, but it's going to be 10 plus days until the service is rendered. We as an organization have to get the GFE provided in 3 days of that scheduled date. So in a case like this, having that patient just come and get it at the front desk really isn't going to be enough. We need to find another way. And we need to find a way that we can get that to the patient. So again, the patient portal becomes a really interesting and I would say appealing option here, knowing that we can get that to them right away. We can have it to them ahead of their scheduled appointment, and we go on down the road. If that patient calls up and we're going to have that service rendered in 3 to 9 days until the service date, that GFE has to be provided 1 day ahead of that scheduled date. So again, day before, they have to be able to have that GFE in hand. And ideally, you want timestamps on all that stuff so you can support that it was done in case it's ever asked and in case it's ever requested. So just know those two things exist. However, a GFE is not going to be required if it's going to be 1 to 2 days that scheduled appointment is made. So your walk-ins, your calls for, hey, I think I need to get checked up for COVID and I'd like to get in today or tomorrow or even the day after tomorrow. Those aren't going to apply for GFE. So you don't have to worry about it for those. Some will still do it just so a patient has a constant expectation of what to expect when they show up for their appointment, and making sure that they know, okay, this is my good faith estimate. Great, I appreciate it. But just know if that is a 1 to 2 days until the service date, you are not required to issue a GFE for those services. Anything else, 3 to 9 days, you have to have it to them the day before the scheduled date. 10 days plus, it has to be within 3 days of the scheduled date. So just have those in the back of your mind as you're starting to develop or refine your processes as needed. The resolution time. So this one is lengthy, to say the absolute least. If there's ever a discrepancy where a patient decides, you know what, I either didn't get it in time or the GFE that I got wasn't accurate, I have an issue with it for one reason or another, they can submit for dispute resolution process for up to 120 days. And they do have to pay a $25 fee to file that. But that's what really starts that. But keep in mind, that doesn't start until 120 days down the road. So we're 4 months post-service, and now all of a sudden we're getting into the dispute resolution process. They have to provide all the information that's provided there, but then the dispute resolution entity is going to notify that patient either electronically or by mail. And they have 21 days to then provide any additional information that either they didn't provide initially or that dispute resolution entity decides they need to have in their hands in order to complete this dispute resolution. From there, the convening facility, so you all on the line, would then have 10 days to dispute the information they've submitted. So this is where the timestamps on your GFE that you provide become incredibly important, because if their complaint is, I made an appointment 5 days before and I didn't get my good faith estimate until a day before my appointment. Well, that actually falls within our requirement here. It was 5 days, we got it to you the day before, we're good. So if you can provide that timestamp to the dispute resolution entity, you're going to be in really good shape. If not, there's going to be more conversations that ultimately have to happen there. Then what will happen at the end of that 10 days is that dispute resolution entity will go through and review all the information from the patient as well as from the RHC and say, okay, based on my review, here's the decision that's been made, and here is the amount, if any, that's due to that patient under the GFE program. But keep in mind, one of the things that benefits everyone on this call here is that the difference has to be greater than $400 from what was provided to the patient than what was ultimately billed. And keep in mind, these are all our self-pay and uninsured patients. So it's not like we're dealing with any contractual adjustments that didn't take place or anything like that. This is strictly, you were in for a level 3 office visit. I said it was going to be, let's say $80, just throw out a round number. And it ended up that we billed you for $500. In that case, absolutely, they could come back and try to issue or initiate, I should say, a dispute. If that patient were, again, to be given an $80 estimate, turns out, yeah, we did that level 3, but we also had to do some labs and some other items. So that estimate actually went up, or the actual billing, excuse me, actually went up to $120. You're still going to be okay because you're not over that $400 threshold. So there's admittedly a low level of risk for our rural health clinics in this area, but I would say the formation and the maintenance of a quality good faith estimate process does need to be in place so that if something were to come up, you're able to defend yourself and you're able to show the processes that you have and show that those requirements were met. So strategic items here that I do want to make sure that we touch on, because these have actually become more and more popular or more and more of a headache for a couple of them here in recent past. And the first is mobile rural health clinics. And the reason that these have gained a lot of traction is because if you're an existing rural health clinic and you decide that there are outlying areas where we're having issues with patients that are able to get to their appointments. We don't have the ability to go get them. They don't have the ability to get here. And so we're having a large portion of no-show appointments in a given area. You can actually implement a rural health clinic, a mobile rural health clinic, and attach it to your existing. It doesn't have to have its own provider number. You can just add this on. And then what happens is it follows the same rules as that existing rural health clinic. So if you're grandfathered, it absorbs your grandfathered rate. If you're subject to caps, it follows the capped rate, and it operates under the existing provider number of that rural health clinic that's already in existence. You do have to make sure that you're meeting all the certification and conditions of participation for the patients that you're going to be seeing, but you don't have to meet them all. And what I mean by that is you don't have to be able to provide, for example, all 6 CLIA wave labs on your mobile unit, because that's actually provided over in the brick and mortar rural health clinic. And that's the entity that's ultimately required to do that. As long as that's done over there, I'm okay in my mobile unit. You do need to make sure that all the areas that mobile unit goes to do reside within a HPSA area. So you do have to make sure that that's the case, and it has to be on a regular schedule with public awareness. So what some organizations that have implemented this have done is had a posting out on their website that says, hey, our mobile unit's going to be at the community center on, let's say, every Friday from 8 to 12. And you can come out and do this, or it's going to be at the local community college from 8 to 12, whatever it is. As long as people know where it's going to be, when, and where they can go to receive services, you're covered. Then you provide your services. Again, you do need to make sure you have a covered provider that's in there. So NP/PA is usually what we see in these. And then if they have those face-to-face visits, they go on your cost report as visits, and you go on down the road. So this can be a really cool and innovative way to reach some of those outlying areas. The other thing that it can do is definitely boost your cost per visit. Because if you need to outfit a mobile unit and you're purchasing that, you're outfitting it, all those things that you're going to do, those are all applicable RHC costs. So at the end of the year, if you have had issues staying above the cap rates as they go up $13 every year, this could be an opportunity to increase some of that cost, provide care to your community. It's just a win-win all around. Hospital outpatient department or RHC status. We have seen, from a CAA perspective, one of the things that it did when it started to quote unquote level the field on the cap rates is really, the new or the main, I should say, remaining benefit for being a provider-based entity is 340B. And so what some entities have done is said, okay, I know there's a lot of requirements and restrictions on rural health clinics. So maybe I initially want to go as a provider-based entity, and then I'll convert to rural health clinic down the road. Maybe it's because my reimbursement right now is above what those cap rates are. If I look at my average reimbursement in my outpatient department, or what I'm going to expect is going to be an outpatient department, and let's say it lands at $150. Well, right now the RHC all-inclusive rate is only $139. Maybe I just go hospital outpatient department. I qualify for 340B as long as my parent hospital qualifies for 340B and participates. And then down the road, as the AIR increases, maybe that's when I'll go over and I'll start to make the transition to a rural health clinic. Again, just a strategic look on some of our primary care offices that we may be considering making rural health clinics. Does it make sense? What's the distance requirement? RHCs don't have that applies to them. Your others certainly will, but it really does require that strategic view of, okay, what's going to be best for me now? What's going to be best for me in 1 year, 2 years, 3 years, 4 years, and developing that roadmap for how we want to transition those departments to either going provider-based rural health clinic right away or moving to a provider rural health clinic down the road. So again, just a couple things to consider there. The last thing that I want to make sure that I mention, and this is a killer for some organizations, if you are considering, and we've seen this a lot because now that volumes have gotten back to what I would say more relative to pre-COVID levels, some organizations said, you know what, we would love to have more space in our rural health clinic. So we'd like to move our clinic. Well, that's great. And I love to hear that, but there need to be some traps run first. And primarily is around the location of that new rural health clinic. Because of the changes that HRSA made, you have to do an eligibility check for that new location down to the address. Don't just look at a county. Get the actual address of that clinic and make sure that it's in a rural area and it's in either a HPSA or an MUA. Because if those things do not apply and you tell CMS, you submit a change of information form via an 855, and you're going to tell them, hey, our rural health clinic is going to move down the road, it could very well be that down the road is an urban area, or at least a non-urban or non-rural area. If that's the case, and you make that move, you would lose your rural health clinic status. The other thing that I'll say is if you are in the process of moving a rural health clinic, make sure that you're continually watching what the designations of that location are so that this doesn't bite you, because the final check that CMS and the regional office will do is do a last look to make sure that that location still meets rural health clinic location requirements. And if one of those things doesn't go, that goes away. And so there's a risk that if you decide to move your clinic and it does end up being a non-rural, non-HPSA, non-MUA, there is a risk that you would go from a rural health clinic with an all-inclusive rate of $139 to now a traditional Part B clinic where you're getting fee schedule. Maybe you're getting $86, maybe you're getting $90, maybe you're getting $100. But there is a significant risk that it would be less than what that all-inclusive rate ultimately may be. So, the big ask that I have of everyone on the line here is if you are even considering making a location change, make sure that you're doing a location check on those items. You can go out to the Am I Rural tool that's provided by the RHI Hub. Again, that's the Am I Rural tool. If you do a web search for that, it'll take you to their site. You put in the address, the zip, and it'll spit out a report that says, yes, this is rural. Yes, this is a HPSA. Yes, this is an MUA, or no to any of those answers as well. But just please make sure you're doing those checks and making sure that you're not going to run into any unintended consequences if you do move that rural health clinic, because we have seen it bite some rural health clinics that we've worked with in the past. And I've actually talked to a couple here in DC that have had the exact same thing happen to them, and trying to get that unwound, quite frankly, is just a nightmare. So again, please make sure that you're doing that check as you go through. I know that puts us right to the top of the hour. Kate, thank you very much. Appreciate you putting that. Kate did just put in the link to the Am I Rural tool in the chat. So if you need to bookmark that, please do so. Again, Kate, thank you very much. I know we only have a couple minutes here. Does anybody have any questions that I can answer before we get to the top of the hour?
Thank you again so much, Steve, for all that wonderful information. And again, yes, everyone, please, if you have any questions, feel free to come off of mute. If you don't feel comfortable doing that, you can also type it in the chat box or email Steve directly. As we wait for those questions here, I am going to go ahead and get those post-polling questions pulled up.
Hey, this is Kevin Hardaway. I have a question for Steve about the mobile RHCs.
Yeah.
Do they have to stay within a certain mile radius or distance from the, I guess you would call it the parent RHC?
There really is no maximum distance stated that they can travel. However, what I would say is, if it's going out, 60 miles, the MAC may have some questions about that. But to that point, if that's your way, we know that there's areas, speaking specifically out in the West, where that's not that far. And I think that's one of the reasons that they tried to keep a maximum distance out of the regs. I guess the way I would answer it is, as long as you can justify that there is a need for your services in that area, and that you are really treating those patients the way they need to be treated and providing that access to care, I really don't see any issues.
Okay, great. Thank you.
Yes, sir. All right. Well, everybody, I really appreciate your time. It's been an absolute pleasure meeting with everybody. Again, for those I haven't met before, it's been great to be with you. For those I have, great to see you again. I will let everybody get back to their day. I'm going to try to pack up as fast as I can and beat the housekeeping staff out of here. Again, if you do have any questions, please feel free to email me. Just know it may be a couple days before I can get on and get a response out to you, just due to travel. But again, thank you, everybody. Again, really appreciate your time. Have a great rest of your week, and hope to talk to you soon.